Welcome to the Explainer. We're jumping right into the ultimate pathology and microbiology board prep guide, specifically designed to help you crush those high-yield diagnostic stains and cellular morphologies. Look, if you're gearing up for the boards, you already know the deal. Spotting the right microscopic clue, it's literally the difference between nailing a question and completely missing a clinical intervention. So today, we're taking those incredibly dense textbook pages and turning them into a fast, highly visual review that's actually going to stick.
Here's our roadmap for today. We're hitting the diagnostic staining toolkit, visualizing bacterial infections, fungal morphologies and stains, parasitic intruders and clues, and finishing up with viral and congenital pathogens. It's a full diagnostic lab journey, moving from your baseline staining tools all the way out to massive systemic clinical complications.
All right, let's kick things off with Section 1, the Diagnostic Staining Toolkit. Time to master the rules of the lab.
You see, building a logical, step-by-step workflow is absolutely foundational. You don't just guess out there, right? You follow a proven pathway. Step 1 is always your broad bacterial screen, using a standard gram stain. If you suspect a specific bacterial colony, you slide right into Step 2 for targeted isolation, using tools like the Ziegler-Nielsen stain. But if your clinical gut says it's a mycosis, you pivot entirely to Step 3, fungal confirmation, where you'll deploy PAS, mucicarmine, or GMS, depending on the suspected morphology.
Now, this comparison table is pure exam gold. It's all about perfectly matching the pathogen to the chemical dye. Memorize these. If you've got a gastric biopsy and you're hunting for H. pylori, you need GIMSA. Looking at lymph nodes for tubercle bacilli, reach for Ziegler-Nielsen or ZN, and pay close attention to those bottom 3 fungal stains. For example, GMS is your absolute go-to for identifying mucormycosis in tissue sections.
To really lock that fungal staining into your brain, keep this super simple memory trick in your back pocket. Just remember, PAS, or periodic acid Schiff, points to the pink hyphae of Candida and Aspergillus. It's a massive visual mnemonic that'll save you serious time on test day.
Moving right along to Section 2, Visualizing Bacterial Infections. We're taking this from clinical vignettes straight to systemic damage. Okay, picture this. Patient presents with bubose and sinus tracts following a recent rat flea bite. That brief little clinical vignette, it brilliantly illustrates the absolute classic presentation of Yersinia pestis, the bacteria behind the plague. The second you read rat flea bite and bubose, your brain should instantly snap to that diagnosis.
And as you know, the plague doesn't just stay localized, it's wildly aggressive. It kicks off at stage 1, the bubonic phase, where those painful buboes and sinus tracts form. If nobody catches it, it rapidly breaches the bloodstream in stage 2, becoming septicemic. Finally, it hits stage 3, the terrifying pneumonic phase, where it becomes highly transmissible person to person through inhalation. Spotting this back in stage 1 is crucial.
Now, let's look at the sheer diversity of systemic complications for staph and strep. These bugs are everywhere, but look at the absolute havoc they cause. Staph can trigger everything from bone infections like osteomyelitis to devastating bacterial endocarditis. And definitely keep an eye on rheumatic heart disease and glomerulonephritis under strep. RHD is a highly tested exam fact stemming directly from an untreated strep infection.
Oh, and whatever you do, do not forget the Clostridial group. These notorious anaerobes drive devastating stuff like botulism, tetanus, and necrotizing enterocolitis. Clinically speaking, if a patient comes in with rapidly spreading tissue necrosis, a basic general gram stain can actually help you identify the colonies causing catastrophic tissue destruction, like gas gangrene.
All right, Section 3, Fungal Morphologies and Stains. Time for some high-resolution visual learning for mycoses.
So, while bacteria often hitch a ride via direct contact or vectors, a lot of fungal infections, mycoses, sneak in through environmental trauma or inhalation. A classic visual cue for environmental trauma is eumycetoma or Medora foot. If your exam gives you a biopsy description featuring unique diagnostic brown granules resting inside an abscess surrounded by necrotic tissue, boom, you're looking at eumycetoma. Those brown granules are your undisputed diagnostic buzzword here.
Let's check out how we differentiate other major fungi based purely on stain uptake. Notice the stark contrast. For candidiasis, we use that PAS stain we talked about earlier to visualize the mix of inflammatory cells, spores, and defining hyphae. But if a patient has neurosymptoms and you draw cerebrospinal fluid, CSF, you're going to need the mucicarmine stain. Knowing whether you're hunting for hyphae with PAS or isolating a CSF sample with mucicarmine is exactly how you separate these species.
On to Section 4,
parasitic intruders and clues. Let's track some protozoal and helminthic diseases.
Let's start with amoebiosis. It primarily causes intestinal ulcers and these distinct masses we call amoebiomas. But here's the catch, amoebas don't like to stay in the gut. Those tissue trophozoites can dangerously spread right through the bloodstream. Identifying those trophozoites early in a biopsy is what prevents severe, life-threatening abscesses from taking hold in the liver, lungs, and brain.
Okay, quick active recall test. Which notorious pathogen features a life cycle where an Anopheles mosquito injects sporozoites that literally have to migrate to the liver to become merozoites before violently infecting red blood cells? Think about it. It's one of the most heavily tested protozoan life cycles in all of medicine.
The answer, of course, is malaria, and this visual comparison of the Plasmodium species is absolutely essential. If you're peering at a blood smear and you spot ring stages and amoeboid forms, you are almost certainly dealing with Plasmodium vivax. On the flip side, finding highly characteristic crescent-shaped gametocytes is your ultimate visual buzzword for Plasmodium falciparum, which is notoriously the deadliest form.
And why is spotting P. falciparum so incredibly urgent? Because the systemic stakes are massive. We're talking encephalopathy in the brain, hepatosplenomegaly, which is that massive enlargement of the liver and spleen, and hemoglobinuric nephrosis. Identifying signs of critical kidney damage due to red blood cell destruction is quite literally a matter of life and death.
Rounding out our parasites, let's talk helminths. These bullet points are the core diagnostic findings you just have to know. Microfilaria? They're readily identifiable, floating right there in a blood smear analysis. Neurocystic sarcosis? You diagnose that by locating parasitic cysts lodged directly in the brain tissue. And a hydatid cyst is instantly recognized by its distinct structural cuticle and inner coelomic cavity. Finally, we've made it to Section 5, viral and congenital pathogens, spotting systemic complications early. Consider this heartbreaking clinical vignette. Newborn presents with jaundice, an abnormally small head circumference, and early signs of heart disease. Whenever you see a newborn presenting with these very specific, overlapping systemic failures, it points us straight toward one major congenital viral pathogen. And that pathogen is congenital cytomegalovirus, or CMV. Look at this list. It really emphasizes the devastating signs of organ damage here. Microcephaly, meaning a severely underdeveloped brain and head. Microphthalmia, which is abnormally small eyes. Combine that with jaundice, structural heart disease, and hepatosplenomegaly, and you can see exactly why rigorous prenatal screening and early diagnostics are absolutely vital.
So, I'm going to leave you with this final provocative thought. Given the catastrophic systemic damage caused by all these varied pathogens we've just covered, from the kidney failure of malaria to the rapid tissue necrosis of gas gangrene, how might missing a single crescent shape or one tiny brown granule in a tissue biopsy completely alter a patient's lifelong prognosis? Understanding the big clinical picture always begins with recognizing the smallest microscopic details. Mastering these visual lab clues is literally the most important studying you will ever do. So keep reviewing, keep connecting those dots, and good luck out there.